Floor is
Thank you,
yours.
Dr. Waqar, and thank you for everybody for coming. Basically, I think Dr. Hassanein started with DVT or thrombosis in unusual sites. Although it's an industrial session, but hopefully you will get a lot of take-home messages. So I changed the topic to VTE journey from diagnosis to full recovery in 20 minutes, since I have 20 minutes. So just to remind everybody that VTE is one of the dangerous disease we deal with significant morbidity and mortality, still one of the leading cause of death worldwide. It starts usually with patient with high risk for VTE, with some kind of trigger, major or minor, one or two. Then the patient might have DVT or PE or both. And you can see that PE can be fatal, and that's where it comes as a third cause of death in cardiovascular after stroke and heart failure and stroke. And if the patient does not die, unfortunately, he's exposed to very high complication with poor quality of life in the form of post-thrombotic syndrome and CTIF. And even CTIF is very progressive disease, and it has high mortality. So our goal always to really recognize it early and treat it early, refer to the specialist early. So our job here basically to start with by effective prophylaxis, and this is where really all patients get admitted to the hospital should have VTE risk assessment in any form of whatever each hospital has, and it's now part of JCA and like KPI. So we talked about the risk factor. For the sake of time, I cannot go through all of them, but we can divide them into two categories: predisposing risk factor and exposing risk factor. But all what we nowadays, there is a shift in the idea of thrombosis and trigger. We try to avoid the provoke and unprovoked over the last few years, because sometimes if we just say provoke and we stop, it will really give the wrong message to the treating physician regarding the extension of anticoagulation. So nowadays we look at the trigger as major or minor, reversible or not, transient or not. So, and most of our patients, unfortunately, even after the first VTE, put them at risk of recurrent. And even each recurrent of VTE carries the same problem we talked about, either fatal PE or increase the risk of post-thrombotic syndrome and CTIF. So again, we have to really treat them effectively, use the appropriate anticoagulation, and the duration is very important, which most of the time in our practice, we're shy on it. So again, I'm gonna go with like a VTE patient journey from diagnosis to recovery. So basically in the diagnosis part, we really should be careful about using optimal diagnostic testing to avoid too much testing, to get accurate diagnosis, and also to try to minimize exposure to radiation in the form of, when we're dealing with rule-out PE for VK scan or CTPE. So we really need to have a high suspicion. We can use clinical prediction rules like Will's score. Nowadays, all the guidelines advise to use age-adjusted D-dimer after 50, and after that, decide about venous Doppler or CT or VQ scan. Each one has advantage, disadvantage. I will not have time to really, but anybody with lung disease, usually CT-PE will be a preferred one. After diagnosis, we should really, when we start initiating the acute treatment, we should at least think about a couple of things. What's the severity of the event, and what's the extension? Is it extensive or not? In DVT, distal or proximal, because the management will be a little bit different sometimes and the duration different. And also for PE, it's a must to do PE severity score. Look for RV dysfunction in the form of either radiological or biomarkers. And then after that, we will decide, is this patient for admission where? ICU, HDU, or the patient can be discharged early. So this is very nice overview from the ASH 22. Give just a quick summary on how after we diagnose VTE, we have the initial management from 5 to 21 days, then we go into the primary treatment, which could be from 3 to 6 months. But again, after the primary, we have to have a decision about to continue or extend the treatment. Later on, I will talk about it more. So for example, this patient with PE, a patient has 47-year-old coming with oral contraceptive pill, comes with symptoms and signs suggestive of PE, but of course it can be different differential. The patient is really sick, tachypneic, tachycardiac, hypoxic, blood pressure on the soft side, no history of previous VTE, no family history of VTE. So you do the Wells score, it comes intermediate as 2.5. So the next step to really confirm was most likely to do D-dimer, which is high. At the same time, of course, the rest of the workup, chest X-ray, not to diagnose PE, it's just to rule out other sure the patient does not have pneumonia or pneumothorax and so on. So this patient goes for CTPE, and you can see very extensive finding bilateral PE in different areas. Venous Doppler was negative for this patient. So European Society of Cardiology really has very nice algorithm for treatment of PE, where after we diagnose it, we really have to do the 2 steps, look at the PE severity score and look for right ventricular dysfunction. This patient, if you plot her numbers on the score, it comes 117, which high level mortality, 30 days mortality 10.4. So this patient definitely needs to be admitted to the hospital and with a close monitor. Her echo showed also all the finding goes with, although the CT did not show right ventricular dysfunction, but the echo showed really significant finding was elevated pulmonary hypertension and all the signs and symptoms of right ventricular dysfunction. So this patient, if you go by the algorithm, go into intermediate risk, then we have to do the troponin and BMP, which really high for this patient. So put her at intermediate high risk. So this patient admitted to HDU with a close monitoring, started on low molecular heparin, and basically in the treatment, we were planning to discharge the patient later on edoxapan, and the reason I'm going to mention here the Hokusai VTE study, which really fit our patients. It's one of the largest study for VTE. Patient randomized initially to 1 to 5 days of enoxaparin or a low molecular heparin, then divided into people on edoxapan, 60 milligram or 30 milligram, and I will talk about it later why 30 milligram versus the traditional way. So unique things about the study, as we said, one of the largest one. Also, it has a stratified randomization and also planned sub-study like regarding the reduced dose and risk factor. Basically, this patient also, people was on anticoagulation from 3 to 12 months, 40% received 12 months. Mimic the practice in the way we adjust the anticoagulation according to the dose and creatinine. And also the patient with warfarin, they had target in range INR 63%, which is good one. So it was planned to reduce the dose, and this is the only study with reduced dose, giving other and NUAC did not have really this in their studies. So patient with creatinine clearance 30 to 50 or weight less than 60, or they have commitment like other medication, PGP inhibitor like quinidine, verapamil, it was reduced to 30 milligram while they are in any of those situations. So looking at the efficacy, it was non-inferiority, which was equal to the traditional treatment. From safety outcomes, it was superior with less major and clinically relevant non-major bleeding. The good things, as we said about this study, which reflect our patient, they had a lot of patients with severe event, either in the form of DVT, extensive DVT, proximal, a lot of patients with femoral iliac vein. Also from PE, it was extensive, like our patient. And also they have a lot of patients with ProMB above 500, right ventricular dysfunction, which makes those patients at higher risk of deterioration. And it's not easy to treat such patients. So looking at that with the people who had BMP above 500, this patient also had the same. The recurrent VTE rate was significantly lower with edoxaban versus enoxaparin and warfarin. And I didn't put another slide, but it's the same when we looked at the RV dysfunction. They usually put it as RV over LV more than 0.1. Again, those patients, they are at high risk. They did much better than warfarin. At the same time, there was people whose milder case, and it showed the same efficacy either inpatient or outpatient. So it really covers the whole spectrum of the VTE. The patient who had 30 milligram dose reduction, it was about 20% of those population, but you can see they maintain the same efficacy, and there was really more safety with it. So again, this is the only study which really showed reduction of dose per the study, showing efficacy and reduction in better safety. So basically, as we see here, like there was edoxaban was very effective, was safer than the traditional. We had different range of patients from mild cases to severe, a lot of severe cases, which give us really confidence with the treatment. And also we had the dose reduction. So to continue the journey, basically, this patient, after 3 days, she got much better, and we start thinking about what discharge. So this is very important transitional of care, where we have to do a lot of education with the patients, with whoever is going to follow with the patient. And also here we have to decide to some degree how long we're going to continue, what anticoagulation, weigh the benefit and risk with the bleeding and efficacy. And later on, of course, what we're really having very weak in our practice, most of our PE, and unfortunately, they don't have routine follow-up. And it's recommended by all the guidelines to have a routine follow-up in 3 to 6 months to look for post-PE syndrome. Most of the guidelines now, we can see that NOAC is the preferred anticoagulation for the majority of our patients. The duration varies, and this is tricky, controversial. There is no too much strong evidence where there will be a lot of decision-making by the physician, weighing the benefit and risk and the patient preference. But you can see here, if there is major trigger, usually 3 months. After 3 months, if there is minor trigger or no trigger, weighing the benefit risk. So for people with low to moderate bleeding risk, we can extend. For high risk, we can stop at 3 months. Same for the European Society of Cardiology. For non-cancer patient, NOAC is the preferred one, except if there is a patient has antiphospholipid, and in particular, treble positive titers. But you can see also here, and I like the European Society of Cardiology recommendation because it's more straightforward than the ACCP and any other. They are very clear in their recommendations, so making it very easy for us. So you can see people without any identifiable risk factor should really consider extension of the anticoagulation, but the same for patient with persistent risk factor or minor transient. And again, in talking to many of the thrombosis experts, nowadays they believe that even minor triggers, there is something going on with the patient, because not every patient on oral contraceptive or pregnancy or whatever has VTE. So those patients might have something else we don't know about, and they are at high risk for recurrent VTE. If for any reason you decide to treat with apixaban, rivaroxaban, because all options are good. Then after the primary treatment, 6 months, you can consider reducing the apixaban to 2.5 BID, rivaroxaban to 10 milligram, just because they have the study. So also, European Society of Cardiology made it very easy by giving this table to help us to decide who's the patient we need to consider extension. I recommend everybody to have it. It will help you to tell the patient what's the risk after you stop anticoagulation. So you can see if it's major trigger, 3 months is enough. If it's high, more than 8% per year, this is most likely easy to extend. The area where most of the physicians are really struggling with is the yellow one, the intermediate 3 to 8 year. And you can see our patient is one of it. But also the European Society of Cardiology made it much easier. They give us the freedom after discussing with the patient, looking at the benefit and risk, that we can really extend the patient. And most likely we should extend the treatment for such patient after, of course, talking to them. Also, you can look at some high-risk factors which make the patient at higher risk of recurrence, especially if there is no identifiable risk factor. And you see, like, I'm trying to avoid the mention and provoke. And also high-risk thrombophilia, proximal DVT, people with cancer, male gender, especially young, they are at very, very high risk of recurrence. People presenting with PE without DVT, they are at threefold higher to come with PE again, like our patient. So basically, the decision is not easy, but needs to be done, and in concordance with the preference of the patient after weighing the benefit. Of course, if there's high risk of a bleeding, you can stop and you can reevaluate. But if the patient low to moderate risk factor, after talking to the patient, many of the patients should be on extension. So it's very important after we discharge the patient to follow up, especially PE. It's recommended in the guidelines as class 1 level B, needs to have routine checkup at 3 to 6 months, symptomatic or asymptomatic. Of course, symptomatic patient, we need to put more effort by doing echo, doing BMB, do exercise test to be sure those patients, they don't have CTIF. They also, European Society has a very nice algorithm with the follow-up of the patient symptomatic, needs echo, then evaluation with the next slide. If not, but they have a high risk for CTIF, and there is very nice table in the guidelines to tell you who's at high risk. Then you will decide to proceed with BQ scan, and then if it's positive, to refer them to CTIF expert. It's very important to detect it early. It's a very high mortality and it's treatable, usually surgical. And in intermediate probability, then we can use maybe the risk factor, the walking stress, the exercise test, and so on to decide. I'm finishing in a couple of slides. So we have a lot of options. The first two, apixaban, rivaroxaban, can be started without low molecular heparin with the loading dose, apixaban 10 milligram BID for 1 week, then 5 milligram BID, no reduction of dose. And this is really very, very crucial in the VTE management. Many of the physicians, unfortunately, they use atrial fibrillation reduction dose. There is no data to support this. And many of the patient and physician, unfortunately, they think that we go middle dose, we're doing right. No, because we're not giving the full protection, and the patient can bleed anyway. So, and there is no supporting data for the reduction of the dose except with edoxaban. Same for rivaroxaban, 15 milligram BID for 3 weeks and 20 milligram once a day. Again, the reduction dose does not have any study. It's only PKD observational study. Edoxaban, dabigatran, because the study was designed that way, and again, you see a lot of sick patients, so they need to be on enoxaparin initially or low molecular heparin. So usually 5 days, then you can continue. So you can see here on the right side, I put some way to talk to the patient and decide which one is the best. Again, remember that the recurrence happen in the first 3 to 4 weeks, especially the first week. So given low molecular heparin in such cases, not wrong. And I think there is some people, they believe like, doing it, it's preventing, or like it's an obstacle. It's not. We used to do it before with warfarin, when so we can send the patient home on it and then decide. So take-home messages, just we need to do a VTE risk assessment for every adult hospitalized patient. Optimal diagnosis test is very important to avoid unnecessary radiation. Evaluating the severity, either DV2 or PE, especially PE. After discharge, we have to have routine follow-up to rule out CTIF and post-PE syndrome. NOAC is the preferred one. Edoxaban, if you see the list I put, it really hit most of them. Low interaction, daily, no problem with food or not. One of the practice also, when we use rivaroxaban, really we have to tell the patient to take it with a heavy meal. So it's only the only one with reduction of. So we have to prevent the first episode. We have to prevent the recurrent one. We have to choose the appropriate anticoagulation, and at the same time have the patient preference in our mind and have discussion with the patient, weighing benefit and risk. And duration is very important. If you're not feeling comfortable with extension, you really should send the patient to somebody who's expert in thrombosis. Thank you.
Thank you